Welcome back to the Deep Dive. Today we're looking at a case that really challenges the standard cause and effect logic we see in oncology.
It's a fascinating one.
It really is. We have a comprehensive clinical presentation of a 35-year-old male named Haji Dil. And honestly, this file is a masterclass in contradiction. You've got this young patient, zero risk factors, who presents with two totally distinct pathologies in his mouth.
At the same time.
It's the kind of case that forces a tumor board to, throw out the playbook and really get into a debate about biology versus guidelines.
And it really highlights this concept of synchronous lesions. Usually when we see multiple spots in the mouth, the first assumption is that it's the same disease spreading.
Right, metastasis.
Exactly. But here we're looking at two different biological processes happening inches apart, and they require completely different management.
And that's our mission for this deep dive. How do you treat a patient when his own mouth is fighting a civil war with two different enemies? So let's start with the patient profile, because this is where the mystery really starts.
Okay.
He's 35 years old, works as a driver in Alta. He comes in with a 2-month history of non-healing ulcers.
And non-healing is the key phrase there. In the oral cavity, anything that hangs around for more than 2 weeks is pathology until you prove it's not. But 2 months, that's actually a pretty rapid progression for the size of these lesions.
Right. And usually when we see oral cancer cases, especially from South Asia, we're looking for the usual suspects.
The big ones: betel nut, gutka, smoking.
Or even just like a sharp, jagged tooth causing trauma. But when you look at Haji's history, it's just remarkably clean. No addictions, no dental issues.
Which immediately raises your suspicion for something systemic or maybe genetic. When you take away those big environmental carcinogens, the smoke, the chew, you left asking, why is this tissue breaking down?
It brings up that idea of field cancerization. Right?
Exactly. The idea that the entire lining of the mouth might just be genetically unstable, even without some obvious trigger.
And speaking of triggers, there was one little flag in his initial labs that we have to talk about. Viral markers for HIV and hepatitis were negative. But his syphilis serology came back positive.
Yes, the classic distractor.
And a distractor.
Oh, absolutely. In medicine, we call syphilis the great imitator for a reason. Secondary syphilis can absolutely cause ulcers in the mouth, but, and this is a big but, the TPHA test stays positive for life, even after you've been treated.
Okay, so a positive test doesn't mean he has an active infection that's causing these specific ulcers.
Not necessarily. So the team is looking at this positive syphilis test and these huge ulcers, and they have to decide, is this a gumma, a syphilitic lesion, or is it cancer?
And the treatment for one is penicillin and for the other
is major life-altering surgery. But the biology is different. Syphilitic ulcers are granulomatous. The body is trying to wall off an infection. Malignancy is proliferative, just uncontrolled growth. When they actually look at the lesions, the syphilis theory probably fell apart pretty quick.
Okay, so let's get into what they look like. The exam describes two very different looking masses. On the right side of his tongue, there's a 2-centimeter exophytic lesion. It's from pinkish, irregular.
Exophytic just means growing outward. And in the tongue, a firm, hard mass like that is really the hallmark of squamous cell carcinoma. That firmness comes from the tumor cells digging into the muscle.
But then you look at his left cheek, the buccal mucosa. This one's described as ulcerofungating, and it's bigger. They say the size of a small lemon.
That term ulcerofungating paints a very specific aggressive picture. It means it's piling up tissue like a fungus, but also dying and ulcerating in the middle. It suggests the cells are growing so fast they're outstripping their own blood supply.
So visually, the cheek lesion was probably the scarier of the two.
Oh, for sure. It would look much more dramatic.
And yet, as we're going to find out, the visual scare factor doesn't always line up with the biological danger. So before they can cut, they need to stage it. They order a CT scan, and this is where the case goes from concerning to, well, critical.
This is the imaging stage. You're looking for depth and for spread.
The CT showed the tongue lesion was already infiltrating the muscle, which they expected. The cheek lesion was digging into the muscle around the mouth. But the radiologist also flagged multiple enlarged lymph nodes on both sides of his neck.
And that is a pivotal moment. In oral cancer, the status of the neck is the single most important prognostic factor.
Why is that?
If the cancer is just in the tongue, survival is high. The moment it travels to the lymph nodes, survival drops by 50%.
50, wow.
Yeah, so that CT finding of enlarged nodes, it basically upstaged him. He went from having localized disease to what looked like regional metastatic disease.
Which changes the entire surgical plan, right? You can't just take out the tumor anymore.
Exactly, you have to clear out the whole drainage system. The surgeons now have to plan for a much more aggressive neck dissection because they have to assume those enlarged nodes are packed with cancer cells.
There's also an MRI report that confirmed the soft tissue spread. It noted the cheek lesion was extending into a gap where a tooth was missing.
Tumors love the path of least resistance. That gap was like a free channel for it to expand. The MRI is what gives the surgeon their roadmap to get clear margins.
So the map is drawn. But before they can operate, they need that tissue diagnosis. They did a biopsy on October 22nd. And this is where the tale of two lesions gets really complicated.
Okay.
The tongue biopsy comes back.
Yeah.
Well-differentiated squamous cell carcinoma.
Right, straightforward. That's cancer.
Yeah.
Well-differentiated is actually a small piece of good news. It means the cancer cells still kind of look like normal cells.
But the cheek biopsy, the report just says squamoproliferative lesion. What does that even mean? It sounds like a non-diagnosis.
It's a pathologist's way of saying, I see a lot of activity, cells are growing too fast, but I can't definitively call it cancer. At least not in this tiny piece of tissue I have. It puts the surgeon in a bind.
But given what it looked like, that lemon-sized ulcerofungating thing, they couldn't just treat it as benign.
No way. You treat the patient, not the piece of paper. Clinically, it looked malignant. So the tumor board made the call to treat both sides aggressively.
So let's walk through that surgery on November 12th. It's a huge operation for a 35-year-old. They do a right partial glossectomy for the tongue.
Which means taking a big chunk of the side of his tongue. That's going to affect his speech, his swallowing. It's not a minor thing.
Then a wide excision of the cheek lesion, and then the big one, the neck dissection. A right modified radical and a left supraomohyoid.
So they're essentially dismantling the lymph drainage system of his neck, chasing down those enlarged nodes they saw on the CT scan. It's a high-risk procedure. You're working around nerves that control your shoulder, your smile. They took a huge calculated risk based on that scan.
And this brings us to the most shocking part of this whole deep dive, the final pathology report, the post-op analysis. Because it turns out the CT scan was basically lying.
Lying's a bit hard, but it was definitely misleading. This is the classic trap of radiology versus pathology.
The report says level 1, 2, 3, 4 V, all of them. Tumor-free. Zero metastasis in any of the lymph nodes.
So all those enlarged nodes that terrified everyone on the scan,
Yeah.
they were just reactive.
Reactive to what?
Inflammation. Remember, he had these big rotting ulcers in his mouth. The mouth is full of bacteria. His immune system was working overtime, so his lymph nodes swelled up to fight the infection. On a CT scan, a swollen node just looks like a swollen node. You can't tell if it's full of white blood cells or cancer cells.
Wow, so that's actually a massive relief for him. Being node negative is the best news he could get.
It's a game changer for his prognosis, but it also means he went through that massive neck dissection for what turned out to be inflammatory nodes. It's the price of safety. We accept that because the alternative, leaving a cancerous node behind, is fatal.
Okay, so let's look at the lesions themselves now, because the final report reveals some microscopic details that are terrifying in their own way. Let's start with the tongue, the confirmed SCC.
Right, so the tumor size was confirmed at 1.6 centimeters with a depth of invasion of 0.6 centimeters, but the real story is in what they call the adverse features.
The report lists LVI and PNI as positive. Let's unpack LVI first, lymphovascular invasion.
So LVI means the pathologist actually saw cancer cells inside the tiny lymphatic vessels or blood vessels around the tumor.
Okay.
Think of it like this. The cancer cells have broken out of the main tumor mass and have basically hot-wired a car. They're on the on-ramp to the rest of the body. Even though the lymph nodes were clear, LVI suggests the transit process had already begun.
And then there's PNI, paraneural invasion.
This one, in my opinion, is even more sinister. It means the cancer cells are wrapping themselves around nerves and traveling along them. Nerves are like a microscopic highway system.
Highway for the cancer.
A highway for the cancer. It allows microscopic cells to get well away from the primary tumor, far beyond what the surgeon can see.
Does that explain why he had no pain? I mean, if cancer's invading the nerve, wouldn't that hurt?
Paradoxically, not always. Sometimes the invasion destroys the nerve, causing numbness instead of pain. But the implication of PNI is a very high risk of local recurrence. The surgeon can cut out the tumor with clean margins, but if there are cells 2 centimeters up a nerve, the cancer will come back.
And the report says his margins were clear.
Right, but PNI makes that clear margin much less reassuring.
Okay, now let's solve the mystery of the cheek. The biopsy was vague, squamoproliferative. The final pathology gives it a name. Proliferative verrucous hyperplasia, or PVH.
PVH, it's a distinct, rare, and frankly controversial diagnosis. It's considered a potentially malignant disorder, but it's on the really aggressive end of that spectrum.
How is it different from the cancer on his tongue?
Well, SCC invades downward. It breaks through the basement membrane and dives deep. PVH grows upward and outward like a warty carpet. It spreads laterally. The cells themselves can look deceptively benign under the microscope, but the behavior is relentless. It has a very, very high rate of turning into a real SCC.
So it's not cancer yet, but it's trying its hardest to become cancer.
That's a perfect way to put it. It's a ticking time bomb. And the fact he has SCC on one side and PVH on the other really points back to that field cancerization idea. His whole oral mucosa is just primed to malfunction.
Which brings us to the tumor board's final verdict. You have a patient with a surgically removed SCC that has these high-risk features, LVI and PNI, and a surgically removed PVH that's pre-malignant. What do you do now?
This is where you go straight to the NCCN guidelines, the Bible of oncology. For the tongue, the decision is driven entirely by that LVI and especially the PNI.
And the recommendation was adjuvant radiotherapy.
Correct. Even with negative nodes, the paraneural invasion means there's a high risk of microscopic disease left behind in those nerve beds. You can't see it, you can't cut it out, so you have to sterilize the field with radiation.
Sterilize the field. Sounds intense.
It is. It's high-energy X-rays designed to break the DNA of any remaining cancer cells. It's an insurance policy against the cancer coming back along those nerves.
But here's the part I found so interesting. They're radiating the tongue side of his head. What about the cheek side, the PVH?
And that is the critical distinction. You generally do not radiate PVH.
Why not, if it's so aggressive?
It's a biological quirk. PVH is notoriously radio-resistant. It just doesn't respond well. Worse, there's actually evidence that radiating a verrucous lesion can trigger it to become a much more aggressive, angrier cancer.
So, radiation could actually make the cheek problem worse.
It could. It's like throwing gasoline on a smoldering fire. So the standard of care for PVH is surgery and then just strict lifelong surveillance. You watch it like a hawk. If it comes back, you cut it out again.
So the plan for him is to blast the right side of his neck and face to kill any invisible SCC cells.
And just watch the left side to make sure the PVH doesn't return or transform. It's a split strategy for a split pathology. It just highlights that you can't treat oral cancer as one thing. You have to treat the specific biology of each lesion.
It's just such a heavy road for a 35-year-old. The dry mouth from radiation, the scarring, the constant worry about the other side recurring.
It is. He's not just cured. This is chronic disease management now. His mouth has proven it can generate 2 different bad actors at the same time.
I just want to circle back to the why of it all. A young guy, no tobacco, no risk factors, just this massive biological failure in his mouth.
And that's still the open question, isn't it? We ruled out syphilis as the direct cause. We ruled out HIV. It leaves you with the uncomfortable possibilities of just bad genetic luck or maybe a viral driver we haven't identified yet.
It's a reminder that even with all our technology, the trigger for cancer in young patients can still be a total black box.
It really is. And that's why cases like this are so important. They remind clinicians not to get complacent. You see a mouth ulcer in a 35-year-old, you biopsy it.
Yeah.
Because biology doesn't always read the textbooks.
And don't always trust the CT scan.
Never trust the scan over the microscope. The microscope is the final judge, every time.
Well, we're definitely wishing Haji Dil the best as he goes through all this. It's an incredibly complex case that required an equally complex solution.
Absolutely. A real victory for multidisciplinary care.
That brings us to the end of this deep dive. We've gone from a driver in Theta all the way down to the molecular highways of paraneural invasion.
It's been quite a journey.
I want to leave you with one thought to mull over. We often think of a diagnosis as a single label. He has cancer. But this case proves that a single patient can be a library of different diagnoses. SCC on the tongue, PVH on the cheek, reactive hyperplasia in the neck, all at once. It forces us to realize the body isn't a single unit, it's an ecosystem. And in this case, different parts of that ecosystem were failing in very different ways. The treatment wasn't just about killing cancer, it was about negotiating a peace treaty with 3 different biological rebellions at the same time.
Well said. Treat the biology, not just the lump.
Thanks for listening. We'll catch you on the next deep dive.